So this morning we made it through the endocrine emergencies, which is the kind of some painful stuff there, no doubt about it. The next topic I wanted to cover is neuropsych, so it's neurology and psychiatry. Why is this important? Well, first of all, we see a lot of this in the emergency department. Second of all, not only do we see it, but it can show up on the board exam. So basically about 8% of the board exam comes from neurology and psychiatry. So in these next, the 2 hours of this talk, basically 1 out of every 12 questions on the board exam can come out of this. So it's a good reason to pay attention for sure. All right, and again, with this, some stuff you know already and you know it pretty well. And I'll try to talk about some of the things that are frankly a little more painful and hard to remember, some of the things like Guillain-Barré and Eaton-Lambert and things that we just don't see every day in the emergency department. But let's start with some basic things. Reflexes in the body. If you remember, C5-6 is the biceps, C7 is the triceps. So 5-6 for the biceps, 7 for the triceps. Pretty simple. When you get down into the leg, pretty simple as well. You remember that L4 is the knee jerk and S1 is the ankle jerk. So L4 for the knee, S1 for the ankle. So when you slip a disc in the back, right, it's usually an L4, an L5, or an S1 nerve root compression. If it's an L4 nerve root compression, you lose your knee jerk. If it's an S1, you lose your ankle jerk. But if it's an L5, your reflexes are normal, okay? No reflex deficit with an L5 disc. So they don't always have to have reflex deficits. So 5-6 for the biceps, 7 for the triceps and the cervical area, and then down in the legs, L4 for the knee jerk, S1 for the ankle jerk. It's pretty straightforward. Okay, dermatomes. You do not have to know every single dermatome of the body, of course, but you should know about the patterns so that when we get to dermatology and see zoster with a dermatomal rash, you'll know what the pattern looks like. In addition, it's really helpful to have a few landmarks, kind of anchoring points when you think about the dermatomes. So if they give you that question about, someone was in a car accident and they had a level at this, at the nipple line or the whatever, what level is that? It's nice to have some anchoring points. So here's what I remember. C4 for the clavicle, T4 for the nipple line. That's pretty straightforward. C4 clavicle, T4 nipple line. And then T10 is the belly button. So the belly button is T10. Okay. The inguinal ligament, the IL, is L1. So L1, IL, inguinal ligament is L1. So C4 for the clavicle, T4 for the nipple line, T10 for the belly button, and then L1 for the IL, for the inguinal ligament, okay? And if you know those, you can pretty much extrapolate between those to figure out where that level might be. Pretty straightforward. Another thing about nerve roots, you can get some good questions on this. Nerve roots in the hand, right? C6, C7, C8, how does that all work? The way I remember this is if you take your left hand and you make an OK sign, and I'm looking at it, right? I'm looking at it, it says OK. I've actually made the number 6, right? It looks like a 6. See the 6? It's a 6. And I made that 6 by putting my thumb and index finger together, and thumb and index finger is C6, okay? So thumb and index finger is C6, C7 is then the middle finger, and C8 is the little finger. So if you just start by making your 6, C6 is the thumb and index, C7 is the middle, C8 is the little finger, and now you have those as well. Okay, cranial nerves. We spent a lot of time learning this stuff in medical school. I'll just give you a quick reminder of what each one of them are, and then I'll maybe make a few points about certain ones of them. We're not going to go through this in, incredible depth. So you remember, first cranial nerve is olfactory for smell. Second is your optic nerve for vision. You remember that 3, 4, and 6 are the ones that move your eyes around, right? The oculomotor, trochlear, and abducens. Those are for your extraocular movements. The fifth cranial nerve, as you remember, is your trigeminal nerve. Trigeminal, it's got 3 branches. Your ophthalmic, your maxillary, and your mandibular branch. So these are sensation on the face. Remember, your 7th cranial nerve is, of course, your facial nerve, all the movement of your face. 8th is the vestibular cochlear nerve, so hearing and balance. 9 is the glossopharyngeal. We don't think about that one so much, but glosso, tongue, pharyngeal, pharynx. Sensation on the back of the tongue and the pharynx is the 9th cranial nerve. 10, you remember, is of course the vagus nerve, all that autonomic innervation, heart rate, bronchoconstriction, GI motility, all that sort of autonomic sort of stuff. 11 is your accessory nerve with your shoulder shrug and your head turn. And 12 is your hypoglossal nerve, the one with your tongue, right? Sticks your tongue straight out if both sides are working. So those are just a quick reminder of what those nerves are. Let's talk about cranial nerve 3, because you know that you can see cranial nerve 3 palsies. Good questions you could write on this. Remember that if you were to look at cranial nerve 3, it's kind of constructed like electrical wiring with insulation around it. You know how electrical wires, they got the wire in the middle, then they got that insulation around the outside of it? That's kind of the way cranial nerve 3 is. The motor fibers are the wires, okay? The motor fibers are the ones going in the middle. And the parasympathetics are the ones that are on the coating. The parasympathetics are on the outside. So if you think about it now, let's just look at one of these cases. This first one here, pupil sparing. So this person's got a third nerve cranial palsy. If you remember, the classic eye position is down and out, right? You've taken third nerve out, but you still got 4 and 6, pulling it down and pulling it out. So right there, oops, let's see if that works. So there's your, this is kind of a weird pointer, but there's your normal one. There's your down and out eye. Okay, so we're looking at that side. But if you look at it, the pupils look pretty good. Pupils look pretty good. So how did that happen? How did you get just the motor fibers, but not get those parasympathetics to affect your pupil size? And that means there was something intrinsic to the nerve itself. So these are like microinfarctions. Think about that. So ischemia, infarction, diabetes, hypertension. This is your diabetic who comes in with a third nerve palsy. When the pupil is completely spared, that's probably intrinsic to the nerve and something just pure motor in the nerve itself. On the other hand, how do you get the dilated pupil? Well, that means something has now messed with the parasympathetics, right? Took away the parasympathetics, so you got sympathetic. So you got a big dilated pupil. So this could be something involving the whole nerve, or it could be something just externally compressing just the outside of the nerve. And when you get that compression externally, the classic thing for that would be a posterior communicating artery aneurysm, a PCA aneurysm. So whenever you see pupillary involvement, that is the pupils dilated, you know your parasympathetics are messed up, something has affected the outside of the nerve, you at least have to consider external compression as the etiology in that patient, all right, and get some imaging. All right, so that's cranial nerve 3. Glasgow Coma Scale, I'm not going to spend a lot of time on this. You probably do this all the time. You remember that there's an eye, a verbal, and a motor that you can get 4, 5, or 6 points for. I kind of just remember them in descending order, like eyes 4, verbal is 5, motor is 6. Okay, that's how I remember it. You get 1 point on each one just for showing up. So the worst you can do is 3, right? You get that EMS call where they say this patient's really sick, we're bringing them in code 3, and they got a GCS of 0. That's pretty sick, all right? You got a GCS of 0. I don't know how you lost points. Like a table has a GCS of 3, all right? So, and again, you know how this works. The more stimulus you have to get a response, the worse the score. Pretty simple. Okay, altered mental status. Again, this is a mnemonic for folks who like it to help them with the differential diagnosis. Not going to spend a lot of time on this. Obviously, we talked about this. Check a glucose in anyone who's altered. Consider thiamine if the person may have Wernicke's encephalopathy. Maybe it's a chronic malnourished alcoholic and they're altered. You might consider thiamine in that case, obviously. Naloxone, Narcan if you think there's an opiate overdose. But flumazenil, we tend, if you remember, that's the one that reverses benzodiazepines. We tend not to give flumazenil in the same way we give Narcan, because when you unmask, you take away that benzodiazepine, they can start to seize if there's something else going on in the brain or if they have a polydrug ingestion and things like that. So flumazenil is great for someone you gave benzos to for procedural sedation and you want to take it away, but it's not so great as your kind of coma cocktail sort of thing. And here's your AEIU tips. I'll just remind you that temperature, being hypothermic or hyperthermic can alter your mental status, right? Being hypothermic can do it, or being hyperthermic can do it as well. Again, I used to work in Sacramento, California, very hot there, especially in the summer, just like here in Vegas. And it seems like every once in a while we get a patient brought in after some sort of blunt trauma, totally altered, head CT, completely normal. And at some point someone finally got a temperature and realized this person had been like laying out baking on the Sacramento pavement for a while, okay? And it was just hyperthermic. So your altered patients, got to get the temperature. It seems that it's always a vital sign that's like deferred, right? A triage, like it's like deferred, like we're deferring until, I don't know, death, I don't know. But get the temperature on these altered patients. It's important. Okay, brainstem reflexes. Anybody done doll's eyes recently? Your last shift maybe, a couple times? Yeah, no? Okay, no. So this is something that's pretty uncommon to actually do in the emergency department, right? But it could show up on the board, so let's kind of go over it real quickly. So doll's eyes reflex, this is when you're trying to figure out if someone's brainstem is working or not, okay? They're clearly altered. You're trying to figure out is their brainstem a problem or not? They're in a coma, is it a brainstem or not? So here's the way it works. So in a normal patient, your eyes, it's going to sound weird, but your eyes move the opposite of your face. And think about it, this was like actually part of evolution when you were tracking your prey, right? You're running after your prey, you're trying to get after your prey, and you're kind of doing this thing, but you don't want to lose your prey. You don't want to be like one of those cameras where your eyes move with your head completely. It looks like one of those, action things like this. you kind of have an internal stabilizer that if my prey's there and I'm doing this, my eyes kind of go the opposite way of my face so I can stay on my prey, okay? And it's your brainstem, evolutionary, that has that trekking mechanism that'll keep you focused on things. So your face and eyes move the opposite direction normally. What happens if somebody has a messed up brainstem? Well, it doesn't work. It no longer works the way it's supposed to. So I'll give you an example. I got a patient. I'm sitting at the head of the bed, right? Their head's here, their face up, feet out towards you. I'm at the head of the bed, like intubating position. A normal doll's eyes, normal thing that would happen, I should say a normal reflex, is I take their face, I rapidly move it to one side, but I just told you that the eyes go the opposite way. So the eyes kind of stay pointed up towards the ceiling. Their prey was on the ceiling, they're looking at the ceiling, I move their face, and their eyes stay up on the ceiling. Okay, that's normal brainstem. That's what's supposed to happen. With doll's eyes, it's called doll's eyes because the eyes move with the face. It looks like the old-fashioned wooden dolls where they used to paint the eyes onto the doll. So I take the doll's face and I move it, the face moves and the eyes move exactly with it, okay? They don't track the prey anymore. That's not normal. It's not normal to be a doll. That's doll's eyes. That means your brainstem is messed up, all right? So that's a brainstem one. Another brainstem or cortex one is cold calorics. You guys do this one a lot? No. This is one where you're squirting ice water in someone's ear and they get nystagmus and they feel horrible and they throw up and that sort of thing. So what's the deal with this? This is the test for someone who's in a coma, whether it's their cortex or their brainstem. And the best way to remember this, I found, is the following story. Imagine that you are driving in your car down the street. Your friend is sitting next to you with a squirt gun filled with ice water and says, you know what, I'm going to just kind of squirt you in your ear while you're driving just for fun, okay? So you're driving along, it squirts you in your ear, this kind of pisses you off at a deep brainstem level, you slowly glare over at your friend, and then your cortex reminds you, you got to look back. Oh, and you rapidly look back at the road again, see what you missed. And then you remember what he did and you slowly look back at him again, and then you rapidly look back. Okay, that's the normal thing that happens with nystagmus when you stick ice water in someone's ear. If I stick ice water in this ear, my eyes are going to slowly move over because of brainstem and rapidly move back because of cortex. So the nystagmus does this. This is what their nystagmus looks like, okay? Slow over, rapid back. That's normal nystagmus when you have a normal cortex and a normal brainstem. That's the normal thing. So how do we use it as a test? If someone's in a coma and you're not sure is it cortex or brainstem, you do the test. You squirt the ice water in their ear, okay? If it's their, let's say, brainstem, my brainstem isn't going to be able to look over at them with that deep glare, right? I'm just going to stay fixed in the middle. So brainstem, it just stays fixed in the middle. If it's cortex, my brainstem looks over, and my cortex can't move it back, so I stay stuck over there. Your eyes deviate towards the ice water, okay? If it's your cortex. Does that make sense? So that's how it works. If you just remember the story, you'll be able to get that right if it shows up on the boards. Okay, corneal reflex, remember this is where you touch or puff some air on someone's cornea, and then both eyes blink, right? So it's cranial nerve 5 that has a sensation, goes back, and then it comes out with cranial nerve 7, makes you blink. Pretty simple. Lateral gaze. So this is kind of interesting, I think. You know, you got your oculomotor nuclei that make your eyeballs move around, but how do they know to move together? How do they know that when this one moves lateral, this one moves medial, right? How do they kind of do that thing all together? There's some connections between those nuclei, okay? And that's called the MLF, the medial longitudinal fasciculus. They're the wires that go between the nuclei and connect them and tell them to move together. And if you get a lesion in that thing, the MLF, it's called an internuclear ophthalmoplegia. Internuclear, because it's not the nuclei, it's the stuff in between the nuclei, and ophthalmoplegia, your eyes aren't moving normally, okay? So here's the way eyes are supposed to move, right? We know this. Here's our eyes, they're moving together. My arms and my eyes here, right? They move like this all together. Now let's give you a right internuclear ophthalmoplegia. With a right internuclear ophthalmoplegia, my eyes move over to the right, looking good so far. They go to move back, and my right eye gets stuck in the nose. It's a midline gaze paresis, so it gets stuck at the nose. If it's a right INO, the right eye gets stuck at the nose and can't make it over. And the left eye can start to develop some nystagmus. And I kind of remember that as like it's going like, hey, come on over, you can make it, that sort of thing, all right? It's trying to encourage you to come over. So that's a right internuclear ophthalmoplegia. A left internuclear ophthalmoplegia, just the exact opposite. So here's normal eyes moving around. Now let's do a left internuclear ophthalmoplegia. They look left, but the left eye gets stuck at the nose when I try to look over. And now my right eye gets a little nystagmus, okay? And there is such a thing called a bilateral internuclear ophthalmoplegia, a bilateral INO, which is where you get both. You look this way, the right eye gets stuck. You look that way, the left eye gets stuck. Whenever you see a bilateral internuclear ophthalmoplegia, go directly to multiple sclerosis. Okay, MS and bilateral INO, it's basically pathognomonic for MS. So when you get that, go directly to multiple sclerosis and you'll get that question right too. Okay, and again, these are just the slides showing you how the eyes move. All right, if you don't have a headache yet, we'll see what we can do. We got more to go. Trigeminal neuralgia. This is actually more facial pain rather than headache. This is from compression of the trigeminal nerve. Can also be from demyelinization of the nerve, but basically compression of the trigeminal nerve. This is going to be somebody, more likely women, but it could be men as well, shooting electric-like pain in the middle of the face. So they get this, ooh, oh my God, this horrible lancing, shooting pain right down the middle of the face. Neurologic exam is totally normal. Motor sensation, cranial nerve, it's all fine. Basically, it's just a shooting, horrible pain that goes down the middle of the face. That's trigeminal neuralgia. You can treat it with carbamazepine. Sometimes they need surgical decompression of the nerve. Migraines, I'll bet you've seen one of those recently, right? Very common, as we all know. Classically young women, positive family history, unilateral, throbbing, nausea, vomiting, may or may not have the aura, right? The flashing lights or the visual changes, things like that. Preventing migraine, we don't tend to do a lot of this stuff, but you can use all sorts of things, beta blockers, calcium channel blockers, even tricyclics, lots of things you can do for long-term maintenance to prevent migraine. Abortive therapy is what we do. Someone comes in with a migraine, we try to make them feel better. Some agents in absolutely no particular order here. The first one, I want to talk about is ergotamine or DHE, dihydroergotamine. Very powerful alpha constrictor. We don't use a ton of this, but it does work. Very potent alpha constrictor. The problem is when any time you do alpha constriction, right, you can kind of elevate blood pressure. So you don't want to use it when there's, think patients with like blood pressure, renal failure, peripheral vascular disease, pregnancy, anything where you don't want to either raise the blood pressure or cause a lot of blood flow constriction. Those would be contraindications for DHE or ergotamine. Sumatriptan, you know about that one. That's a serotonin agonist. Again, it works pretty well, although there is some rebound where they do better initially, and then all of a sudden they come back several hours later and their migraines returned again. The thing about sumatriptan is it has the same sort of adverse effect profile as ergotamine, and so because of that same sort of contraindications, and you don't want to use the two of them together, within 24 hours of each other. So if somebody used their sumatriptan at home, felt better, and then it got worse and they came back in, I would not reach for the DHE and give it to them because you're kind of doubling down, so to speak, I guess in Vegas talk, right, on all the alpha effects and those sort of bad side effects with it, so you don't want to do that. What we use, of course, first line are the dopamine antagonists. These are the antiemetics. This is like prochlorperazine, promethazine, metoclopramide, compazine, phenergan, Reglan, those sort of things, right? 10 milligrams of compazine IV. Magic stuff for migraines, works very well. And of course you can use other things. You can use Toradol, you can use droperidol. We don't use it that much anymore because it's, first of all, it's obviously off-label, but also the black box warning. But it actually works quite well for migraines as well. And yes, every once in a while, you got to get down to the opioids. We try not to, but sometimes you end up with the opioids. Again, this is stuff you do all the time. Cluster headaches. Why are they called cluster headaches? They come in clusters, pretty straightforward. Middle-aged man, horrible unilateral headache, back on this one side, back behind his eye, and he's got some eye findings. He's got a small pupil. He's got some conjunctival injection. He's got some tearing, things like that going on. So these kind of little ocular findings in the one eye and really horrible headache. And they come and then they get better, and then they come and they get better, and they come in these clusters so they can have multiple of these headaches. They actually don't last, each headache itself doesn't last that long. One of the reasons that you may not see it in the ED, because by the time they got in, it's gone, or by the time they get through your waiting room, it's gone, okay? But they do occur in clusters over and over. The thing to remember about this one, what's different, you can use all sorts of things to treat it, but what's different here is the 100% oxygen, right? So 100% oxygen is a great and is a preferred treatment for cluster headaches. So if they give you that person either on the boards or in your ED, you think it's a cluster headache, oxygen is the answer. There are patients who you're giving them all sorts of opiates, they're not getting any better. You stick the oxygen on them and they get better. All right? So 100% oxygen for cluster headaches. Tension headaches, that's just the stuff half of you probably have right now, right? Bitemporal, occipital stuff. No, they don't have nausea, vomiting, and photophobia. It says not aggravated activity, but I'm going to tell you, I think probably every headache is aggravated by activity. But it's just more of the tension sort of headache. Toxic metabolic is just to remind you that there are systemic things that can cause headache, right? Carbon monoxide toxicity, alcohol use, hangovers, all that sort of stuff. Systemic things can do it. Fever can even cause a headache. All right, next disorder we want to talk about, pseudotumor. So pseudotumor cerebri, also known as idiopathic intracranial hypertension. You get a young, obese female. So you got like a 25-year-old, 26-year-old woman comes into your emergency department, obese, she's had some amenorrhea maybe, and she's had this really bad headache. It's just kind of a global headache all over. It's been lasting days and weeks. She's had some nausea with it, maybe even some faint visual, vision's just not quite as great as normal. And it's worse when she lays down in Valsalva's and you're thinking, oh man, I can't believe I'm about to diagnose a brain tumor in this young person. This sounds horrible. It sounds like a brain tumor. So you go ahead and you get the CT scan, and it's normal. CT is normal, no tumor, okay? It's not a tumor, as the governor would say. All right, so CT scan is negative. Maybe the ventricles are a little small, so either normal or slit-like ventricle. So not very impressive head CT. You're like, man, that's kind of interesting. And you go ahead and do the LP, and the opening pressure is very, very high, okay? Very high pressure. So what is happening here is you have impaired CSF absorption, and because of that impaired absorption, the pressure builds up in the ventricular system. It doesn't dilate, I don't know why, but it doesn't, but your pressure is elevated without your ventricles being big. So CT is normal, or even maybe small ventricles, and the LP shows elevated opening pressure. On exam, these patients actually may have papilledema that you can see, because they get very impressive papilledema. And usually my fundoscopic exam is not very good in the ED, right? I'm like, the lights are too bright and you're trying to turn them down and there's only that one that turns off in the room, right? You've had those same rooms. There's only like one that'll turn off and you're in there looking like this. And by the end, I'm like, fundi present, that's pretty much it, That's all I'm getting out of there. But these patients, you actually may see the papilledema because they really have a very impressive papilledema. So it is worth looking if you think that they have pseudotumor. Anything that causes increased intracranial pressure, for any cause, for big increased ICP, can get cranial nerve 7 palsy. Okay, I'm sorry, 6. I misspoke. Cranial nerve 6 palsy. Cranial nerve 6 palsy. Lateral rectus. Okay, so anything with elevated ICP can give a cranial nerve 6 palsy. So that can happen here as well, but it's not specific just to this. Okay, so you got the head CT, it's normal, you did the LP, the opening pressure's high. How do we treat this patient with pseudotumor? Basically, we need to get rid of the pressure. So they'll do repeated LPs to bring down the pressure into the normal range. They'll use acetazolamide to decrease the production of all this fluid, this extra CSF that's building up there. Sometimes weight loss can help as well. And they can do different surgical shunts. They can do like an LP shunt. They can do optic sheath fenestrations and poking little holes and things like that. So ways to basically drain the fluid, think about that, or reduce the amount of fluid. So that's pseudotumor. It's not a tumor. It sounds like a tumor, bad headache. You think they're going to have a tumor, but the scan is okay, and the opening pressure is high. Post-concussive headache we see all the time, right? Someone's got a concussion now, or some head trauma. Now they got a really bad headache. Can last a day, can last weeks, can last much longer. Can go along with the whole post-concussive syndrome, where they have changes in personality, difficulty sleeping, memory, attention, depression, all sorts of different things that can happen. Nausea, right, with post-concussive headache. You know about that. Spinal headache. So somebody comes into the ED with a headache. We do an LP, and now they got a worse headache, right? This is the post-dural puncture headache. This is where you actually have done an LP, you've drained off some fluid, and no one knows exactly why, but it seems like the more fluid and the faster you're draining it off seems to be correlated with this post-dural puncture headache. Almost all of these will occur within 3 days of the LP. So if the person was LP'd a week ago and comes back with a headache, it probably wasn't their post-LP headache. There may be something else going on with that person, all right? They almost all occur within the first 3 days. And again, it seems that the more fluid that you drain off or the more kind of you muck around down there, the worse. So we know that if you use a bigger gauge needle or multiple attempts or drain off more fluid, all of those things are associated with increased risk of post-dural puncture headaches. Some other tips we know that if you ways to reduce post-LP headache, if you put your little stylet in back in before you pull your needle, that helps actually, helps reduce it. Doing it so that how am I going to describe this? Your bevel is perpendicular to the spine. So for example, if I have the person laying on their side, right, they're laying sideways, I'm going to do their LP, I want my bevel up towards the ceiling, not towards their head. Does that make sense? So you want that little dot up towards the ceiling and put your stylet back in before you pull out. That's really important. Also, those, what do you call them? The cutting needles, right? The ones that anesthesia uses, those, what is it? Quinky, thank you. Yeah, the Quinky ones, these Quinky ones. That now you don't get the same pop you get with the regular needles that are in the LP kit, but those absolutely will reduce post-LP headaches. So if you're able to use those and you're adept at using those, that's a fantastic way to reduce post-LP headaches as well. Treating spinal headache, you can give fluids, you can give some caffeine, but the most important, like the definitive treatment, is the blood patch. And anybody here done these? Somebody? Usually one in the crowd. Not seeing anyone. Okay. I've never done them, but I've heard that they're not too hard. But the way the concept here is you take the patient's own blood and you take 10 to 20 cc's of the patient's own blood and you go back in the same space or one space up where you did the LP into the epidural space and you inject it. And you inject it, it's supposed to make a big clot, it's supposed to stop the leaking, and the patient gets better. I don't know if that's exactly how it works or not, but it's like 85 to 95% effective. So it works really, really well. So if somebody's got a bad post-LP headache and things are not getting better, with just some of the mild usual treatments, this basically blood patch is where you want to go. I usually call anesthesia to do it. They do it in our emergency department, but some people have learned to do it themselves. There you go. Now I'm going to take a 1-minute detour where you can put down your notes if you want, because I do always like to share this article when we talk about post-LP headache, because, I don't know, I find it a little bit uplifting, all right? You've been sitting here for a long time, so we'll do a little uplifting, just for a moment. So this was interesting. This was from an article. It's one of my favorite articles about atraumatic lumbar puncture needles, okay? But the reason this is my favorite article is because of the introduction. I mean, it's a good article, but the introduction was just killer, all right? In the introduction, they talked about how they discovered post-LP headaches, these post-dural puncture headaches. So again, I'm going to read a little bit of this to you if my eyes will cooperate, just to give you an idea. All right, ready? Here's the story. So Dr. Heinrich Quinky of Kiel, Germany, introduced the concept of diagnostic LP in 1891. A student of Dr. Quinky, the German surgeon Karl August Beer, and his assistant August Hildebrand, this are two Augusts here, attempted the first spinal anesthetic in 1898 by subjecting each other to lumbar puncture and injection of cocaine into their intrathecal spaces, okay? So you just got to have the picture. You got like the two August brothers. They got some needles. They got some cocaine. They're like, hey, let's try this and see how this goes, all right? So they go ahead and do this, and injecting each other in their intrathecal spaces. Neurologic examination aimed at confirming the loss of sensation in the lower extremities included application of burning cigars, strong blows with a hammer, deep needles to the femur, pulling out pubic hairs, and intense pressure on the testicles, okay? These are committed researchers here we got going, okay? These are committed researchers. So then they say in the introduction here, a night of revelry with drinks and smokes followed the successful anesthetic. However, the next day, Beer and his assistants suffered the debilitating consequences we now clearly recognize as a syndrome of post-dural puncture headache, okay? And they were probably hurting in other places too. But anyway, that's the story. So now you know how we got with it. That's spinal headache. Okay, cruising on. Subarachnoid, bread and butter emergency medicine. You remember this is an aneurysm or an AVM. It pops. Terrible headache, right? Remember this can occur in patients of all ages. You may have that sentinel headache, that warning leak, which is really just a small subarachnoid hemorrhage. And of course, how do people describe subarachnoid? What are we classically taught? What is it? Come on, yell it out. Worst headache of your life, right? Acute onset, worst headache of your life. Now, do you ever ask patients in the emergency department, is this the worst headache of your life? Yes, okay, don't do it, because what happens every time you ask that? Of course it's the worst headache of your life. You spend the next 15 to 20 minutes going like, are you sure it's the worst headache of your life? Are you really, but what about a week ago? Well, do you see this needle? That sort of thing, right? So, don't ask them if it's the worst headache of their life, because they always say that. You got to kind of approach this from the side. You got to slide into it a little bit, right? So go in, you introduce yourself, you seem very, empathetic. Oh, I can see you're uncomfortable. We're going to get you something for your pain, all that good stuff. You start asking them all the usual history stuff, right? And then here's the key question. When is the last time you had a headache this bad? Okay, and when's the last time you had a headache this bad? And everyone does better on multiple choice rather than fill in the blank, right? So give them some options. When's the last time you had a headache this bad? Like a week ago, a month ago, 5 years ago? I can see this is a really bad one. When's the last time you had one this bad? And they go, oh, well, yeah, this is bad. It was like 5 years ago. And you're like, boom, we're done, all right? Not the worst headache of your life. Don't even come with me at that, all right? No, we're not going to hear about it, all right? Don't come with me, all right? So that's the question. You got to slide into that, otherwise you're going to be like CTing everybody and their mother. Okay, so but acute onset, worst headache of their life. And yeah, they may have some neck pain and stiffness, but certainly don't count on it. As you know, CT will show most of them, particularly within the first 6 hours. So, you know, blood, just like with trauma patients, you know how blood goes from white to brain color to black, like CSF? It's no different in subarachnoid hemorrhage, and there's just a smaller amount of blood. So acute blood is white, but not too long after that, it starts to go away, and it gets harder to pick up on the CT scan. So it's really best within the first 6 hours. Beyond 12 hours, definitely do not rely on your CT. Frankly, I wouldn't rely on it beyond 6 hours, but it's really best within the first 6 hours of onset, your head CT. After that, it could miss it, all right? If you got the head CT and it's negative, and let's say it was within 6 hours, you might be able to just do shared medical decision making and say, look, we could do an LP, we could not do an LP, here's the risks, you decide, okay? But if it's outside 6 hours, in my opinion, I think then you need to go ahead and do the LP, all right? Because the CT is just not good enough at that point. You do the LP, and what you're looking for is xanthochromia. You remember that's the breakdown product of the heme and the hemoglobin that turns the clear CSF to that pale yellow. That's what you're looking for, the breakdown product there. Remember, it takes about 6 to 12 hours for that to develop. So if their acute onset headache was 2 hours ago, don't be surprised if there's no xanthochromia on your LP. The other thing you're looking for is red cells themselves, right, from bleeding. But as you all know, and I'm sure have experienced, the dreaded traumatic tap where you go in there and like that first tube, you're like blood. I'm like, oh, was that me or was that the subarachnoid, right? Which can be really hard. And how do you tell a traumatic tap versus not? The truth is it's hard. You know, of course, you're looking for declining red cells in tube 1 to tube 4. If it goes from some high number to normal, fine, that was traumatic. If it goes from some high number to maybe just a hair more than normal, I'll probably live with that one too. But if it goes from like 5,000 red cells to 200 red cells, I don't know what to make of that, you know? I mean, yeah, there was a traumatic tap, but I haven't really ruled out that they started with 50 or 60 red cells before I did my traumatic tap. You know what I'm saying? So you just got to be really careful when it's coming down but not either at or close to the normal range before calling something a traumatic tap. What do you do when you're not sure if it's a traumatic tap? You know, we used to admit them and do it again or go up a level, all these sort of things. It's just easier now. You just CT angio their head. You do the CT angio looking for the aneurysm itself. If there's an aneurysm, call your friendly neurosurgeon. If there's not, then they're not going to do anything about it anyway. I think you're done, okay? So that's kind of the practical approach to this. Okay, so you get your head CT. If that's negative, if it's early, shared decision making. If it's later, go ahead and do your LP. Treatment, blood pressure control, neurosurgery consult, admission, nimodipine to reduce spasm, right? Remember that they get spasm that occurs after subarachnoid hemorrhage. They can also get rebleeding later as another complication of subarachnoids, as well as obstruction hydrocephalus, where the blood plugs things up, other complications of it. But the nimodipine's for spasm. Okay, pretty pictures of subarachnoid. You see, I work at one of these tertiary quaternary academic health centers, so we have these new CT scans where the arrow just prints out automatically. It's awesome. Don't even need the radiologist anymore, just the arrow. That's it. Not quite there, although we might be getting there with AI. You never know, right? To some degree. So here's some subarachnoid hemorrhage. You can see it all around the basal cisterns. You can see in the lateral ventricles there, right? All over there, over there. Okay, subarachnoid. Let's talk about hydrocephalus a little bit. So hydrocephalus is when the ventricular system kind of gets plugged up, right? There can be obstructive and non-obstructive. So obstructive or non-obstructive or communicating, right? Non-obstructive or communicating hydrocephalus. Obstructive is where there's something that's blocked up the ventricles along the way. So, you know, you're going to get a head CT and you're going to see like big lateral ventricles and maybe a big third ventricle, but oh, the fourth ventricle is really small. So things are asymmetric because some things have plugged things up there. A tumor, neurocysticercosis, a malfunctioning shunt, whatever, right? You know about this stuff. So diagnosis on head CT, you do not want to LP that person because things are not communicating. So you don't want to LP him and suck the head down or the brain down in through the, and have him herniate, whatever, that sort of thing. So do not do an LP in somebody with an obstructive hydrocephalus. Treatment for that is a shunt. They need a ventriculostomy from the top or a shunt to drain things out, right? That's surgical. What about non-obstructive? Well, first I want to tell you about this thing called hydrocephalus ex vacuo. Very simple. It's just a radiologist's fancy term for bad atrophy. That's all it is. It's just bad atrophy. Instead of saying the head CT showed bad atrophy, I don't know, maybe they get paid more or something. They say it showed hydrocephalus ex vacuo, okay? That's all it is. It's just the brain is so shrunken with atrophy that the ventricles look like hydrocephalus. That's all that is. But then there's this disorder called normal pressure hydrocephalus. And this is really important. This is a really important one, okay? Very testable and really important for practice, because this occurs in elderly patients and they get dementia, right, as part of one of their symptoms. But this is a potentially reversible dementia. If it's from NPH and you fix the problem, the dementia's gone. That's not most dementia that we experience, right? Most dementia, they got it. Things are only getting worse from there. So this is not Alzheimer's, this is not Parkinsonism, but it can cause dementia that could be reversible. So how do you make this diagnosis? There's a triad, and the ones I would circle are dementia, ataxia, and urinary incontinence, right there in the middle of the slide. Dementia, ataxia, and urinary incontinence, otherwise known as wet, wacky, and wobbly, if you like that one better, all right? But they're all, these are elderly patients who are demented, they have ataxia, they're not walking real well, and they have urinary incontinence. And if you think about it, those things are common in elderly patients to begin with, right? Maybe some incontinence, maybe their gait's not as good, maybe they're having a little bit of dementia. But if you see those three lined up in front of you, an alarm bell has got to go off. Ding, ding, ding. Could this be NPH? Is that what's going on with this patient? That's their dementia, is that they have normal pressure hydrocephalus, okay? So you thought about it. They have the triad, so you do the head CT. And your findings are just what the name says, normal pressure hydrocephalus. So on the head CT, hydrocephalus. If you do the LP, normal pressure, okay? So normal pressure on the LP, hydrocephalus on the head CT. It's the exact opposite of pseudotumor, so you can remember it that way too, all right? Exact opposite of pseudotumor. So normal pressure on the LP, but enlarged ventricles on the head CT. Pretty simple. And the treatment for this is basically shunts. What they'll do is they'll take the patient and they'll walk them, and they're really ataxic. Then they'll do like a high volume LP, take a bunch of CSF off, and they'll try them again and see if they get better. And they're like, oh, they're kind of walking better. That might be a good surgical candidate for a shunt. And then they'll go in and do a shunt and drain that fluid from them, okay? Normal pressure hydrocephalus. Dementia, ataxia, urinary incontinence. Very testable for the boards. So here's some pictures of hydrocephalus. I think you can see what's going on there. You see the big ventricles everywhere, lateral ventricles. You see the shunt sitting there in the ventricle too. Shunt sitting in the lateral ventricle, posterior horn back there. Okay, so that's just some big hydrocephalus. And that might be obstructive because I'm seeing, big lateral ventricles, maybe some big third ventricle here. Where's the fourth ventricle? I don't really see it down there. So maybe there's some obstruction going on there. I don't know. Oh yeah, well there's definitely obstructive. Look at that one. Yeah, definitely. I don't see any fourth ventricle there. Third ventricle looks kind of small too. So that's obstructive hydrocephalus. This one on the other side is just hydrocephalus ex vacuo. Bad atrophy. That's all it is. Bunch of bad atrophy, brain shrunken. That's hydrocephalus ex vacuo. Okay? Shunt headaches. Let's talk about ventricular shunt headaches. You remember the way these shunt works. They're all essentially one-way valves. They're draining the CSF from up in the ventricles to somewhere else, right? Peritoneal cavity, wherever. Okay, so they're all one-way drains. And if you remember, you got the limb that starts in the ventricle, and then you may have that little reservoir under the scalp, that little balloon thing that you could push down and compress and let go, and it refills, that sort of thing, right? So you got that under the scalp, and then you got the distal limb that goes down and drains it somewhere. That shunt obstruction, we always examine the shunt, right? And we push down, we say, hey, does it compress and release? If it does, it makes you feel a little better. It's not a shunt obstruction, but it's not a good enough test to rule it out. So you still got to get a head CT, all right? If it's like jammed, you're like, okay, I'm really worried now, okay? But that's what the little reservoir is. So one-way valves, they all kind of drain CSF out of the brain. Before I get to that, let me just say, so when somebody comes in with a shunt and a headache, we always think about two things, obstruction and infection, right? Obstruction and infection. Obstruction, you just got to get the head CT and you got to compare it to their old one because it's always abnormal, right? Infections almost always occur within 6 months of the shunt being placed. Most of them, honestly, within 2 or 3 months of the shunt being placed. So if someone has their shunt in place and they come in with a headache 2 years out, that's probably not a shunt infection. It could be an obstruction. Get their head CT, and if it looks abnormal, remember you get that shunt series, which are just plain films following the shunt all the way along its course to see if it's kinked or anything like that, all right? But you know, infections are usually early, within the first 2-3 months, certainly within the first 6 months. Okay, so what happens when somebody's got a bad obstruction? They got a shunt in place, they got a bad obstruction, they're going down the tubes right in front of you. You want to get this thing decompressed. You call your neurosurgeon and say, hey, got a 10-year-old with a shunt and their mental status is declining right in front of me. I think they're herniating. Can you please come in and tap this shunt? And they go, absolutely, I'll be there in an hour. And you're like, seriously, that's not really that helpful, right? So you're going to have to do something. You're going to have to try to tap the shunt. So it's worth knowing about how to do it. Again, I do not go at the start of my shift wanting to tap shunts, okay? I'm very happy to leave them alone and let the neurosurgeons deal with it. But if you get in a bind and you absolutely have to do it, this is how you would do it. So again, just reviewing the anatomy real quick. You got your proximal limb up here. Then you got your reservoir with the little button thing where you can press on it, you know, the compression thing. And then you got the distal limb draining it out down there, okay? So what you do is you get yourself a little butterfly needle, like 23, 25 gauge butterfly, hook it up to some tubing, hook that up to a manometer you can see there, the 3-way stopcock, the usual deal. Obviously sterile prep and drape everything. Go ahead, put the needle in there and measure what the pressure is. Now remember, normal pressure is less than 15 centimeters of water. So it should go up to less than 15. That's normal. So let's talk about some various scenarios that could happen here. You put the needle in, no fluid comes out, or a little fluid comes out and the pressure's really, really low. Where's the obstruction? Proximal, right? It's up here. You blocked everything up here proximally so that no CSF is flowing into that thing, or it's very low. It's a proximal obstruction. You can't do anything about that. That person needs to go to the OR and have it fixed. So you're just going to have to wait till the neurosurgeon. You can give mannitol and all those other sorts of things, but you can't fix that because it's a proximal obstruction. Let's say, on the other hand, you put the needle in and Old Faithful, right? It's like going up and, 15, 20, 25 centimeters of water. Pressure's really, really high. Where's the obstruction there? Distal, right? You got a distal obstruction, and now the fluid's backing up. You can do something about that. You start to drain off the fluid until you get it back into a normal range, okay? Get it back down below 15, all right? So basically, the person's got a shunt obstruction and they got a high pressure there when you tap it. Great, you can fix it by bringing them down, temporizing at least. But if it's low pressure, you're kind of stuck. And again, once you bring it down, that's just temporizing. They still got to go to the OR and get it fixed, but at least you were able to do something for them. Okay, make sense? Okay. Okay, mass lesions. Let me just give you a few factoids here. Subdurals versus epidurals. Again, I think you know this stuff, but let's just kind of give you a few little factoids. Subdurals are more common. They're associated with the bridging veins. So basically, classic for this would be alcoholic or elderly patient, who's got a little brain atrophy, that sort of thing. Their little bridging veins are started to stretch tightly as their brain shrinks. They walk, they fall, they hit their head, they shear these bridging veins. You now have a venous bleed in the subdural region. Subdural means it's under the dura, so it's next to the brain. So it follows the shape of the brain. It's a crescent shape going around, just like the hemisphere, around the shape of the brain. That's your subdural hematoma. It can be acute, meaning white on CT. It can be chronic, meaning black, like CSF on CT. Or it can be subacute, where it looks the same color as the brain tissue. And that can be tough to pick up. You've got to be really careful about those, all right? Subdurals actually have a worse prognosis than epidurals, just because there tends to be more associated brain tissue damage with them, okay? More brain tissue damage. All right, so that's the subdurals, bridging veins. Epidurals, classic thing here. You're golfing with your buddy, you cheated, you pissed them off, they hit you over the head with a golf club, right? Strong force, small area, temporal bone skull fracture, tears your middle meningeal artery. So we got a skull fracture here, you got a middle meningeal artery, so you have arterial bleeding there. You're knocked out, and then you kind of wake up, you're like, whoa, that wasn't cool, dude, that sort of thing, right? And you're not feeling so great. And then you got some initial bleeding there, and then you're in that lucid interval where you're doing okay, but as the blood starts to accumulate more and more and more and more, you start to get increased ICP, and you start to herniate and go down, right? So that's your classic epidural hematoma. So trauma, temporal bone skull fracture, middle meningeal artery, arterial bleed, lucid interval potentially, and then you start to go down. At least that's what can happen. Let's look at some pictures. Okay, this is a subdural under the dura, following the shape of the brain. It looks more like it's following around the crescent shape of the brain there, okay? And you can also see that there's some midline shift on this, right? Midline shift, compression of the lateral ventricle there. Okay, so subdural hematoma with some mass effect. Epidural, let's look at this just top middle picture just to give you a nice picture. So the dura is right there. That's the dura, sorry, right there. And it's being peeled away. So this is epidural, above the dura. It's got to peel that dura off of the skull. And that's why it's more like a lens shape pointing in towards the center of the brain. Right, that's your epidural hematoma. I want to show you, I want to just mention one other teaching point real quickly. All right, so that subdural is obviously an acute subdural, right? It's bright white. Imagine if that color of that was subacute and it was the exact same color as the rest of the brain tissue. And imagine there wasn't midline shift to, give us a hint of mass effect. That could be really hard to pick up. It just looks like the brain, right? How would you even know? So here's the trick I want you to remember for this, which is whenever you're reading a head CT for trauma and you're worried at all about the potential of an isodense subdural hematoma, you need to follow the gyri, those sulci, that go into the brain, all the way around the circumference of the brain. And if you did that, again, imagine that this is, brain color, not white, just for this purpose here. I'd start over here and I'd go, oh, look at those nice sulci. Look how they go in. Look at those sulci and those sulci and those sulci. And I'd come around here and, oh, look at that little sulci. And then when I'd hit here, I wouldn't have any sulci because I'd have subdural there, right? So always look for sulci all the way around the brain. That's how you can pick up a isodense subdural hematoma. Okay, and there was the epidural. And this is just like cerebral contusions. Looks like little white popcorn in the brain there. Lots of contusions. Mass lesion, I think Ken made this point, and the only point I'm going to make from this already is that the most common mass lesion in the brain of someone who has AIDS is toxoplasmosis, okay? Toxoplasmosis. So he talked about the headaches and all the symptoms and that sort of stuff. So toxoplasmosis, ring-enhancing lesion on CT scan in the brain, someone with AIDS, most common mass lesion. Meningitis. Let's whip through meningitis. You know about meningitis. Let's do it quickly. Headache, nuchal rigidity, petechial rash, that would be great. Remember that in infants it may just be, irritability, poor feeding, things like that, so you got to be careful. I'm going to remind you about Brzezinski's and Koenig signs for the exam, and then I want you to forget them for at least the next 10 years, okay? So you ever have to take this thing again. Well, although now they got this new format, who knows, all right? But they are absolutely worthless in clinical practice. They are horribly insensitive, horribly not specific. So let's learn them real quickly and then erase them as soon as you take the test, all right? So if you remember Brzezinski's sign, this is the one where you flex somebody's neck like this, and they kind of flex up their hips and go, ow. So you go like this, and they go, oh, that hurts, okay? They flex up their hips when you bend their neck down. That's Brzezinski's sign. Koenig's sign, this is the one where you take their leg, you lift it up like this, you flex their hip, and then you go to extend their knee. Ouch, sorry, ouch. If you extend their knee and it causes pain, they've got meningitis, okay? Right, so I have meningitis because that hurt, Clearly, Dr. Koenig practiced at a time when people did a lot more yoga and all sorts of things like that, right? Because everyone would have it. That's why it's a worthless sign. But then I remember that K, Koenig, knee, right? K, knee, Koenig, Brzezinski, that's the other one, all right? Or B, bend the neck, I don't know. But that's the other one, all right? Koenig, K, knee, you'll remember that. There they are, doing the tests. Okay. If they got petechiae, think about meningococcemia. That's pretty obvious. On the LP, with somebody with bacterial meningitis, remember, pretty much everything goes up except the glucose. So opening pressure is high, white cells are high, polys are high, but the glucose is low because those bacteria and white cells have been like chewing up the sugar, all right? So everything else is high in bacterial meningitis. Remember, gram stain is not very reliable if you've already gotten some antibiotics, although, it's over time. It's not like it immediately goes away when you get a first dose of antibiotics. Over the age of 1 month, there are 2 bugs that are the most common cause of bacterial meningitis, and these are the ones we're always covering. Pneumococcus and meningococcus. So strep pneumococcus, so strep pneumoniae, and Neisseria meningitidis. Those are the 2 bugs over the age of 1 month that you always got to cover. Always got to cover those. You may broaden for something else in special cases, but it's always pneumococcus and meningococcus you got to cover, okay? And you know that there's obviously ceftriaxone-resistant pneumococcus, and that's why we're always adding vancomycin as well, all right? The bottom yellow box is really important. Someone's got bacterial meningitis. You want antibiotics on board quickly, right? You do not want to wait for the CT to get ordered, and then finally to be in line, and then the radiology reads it, and then you find the LP kit, and you consent him, and you do this thing, and 6 hours later, you're so proud of yourself you've made the diagnosis of bacterial meningitis. Meanwhile, their brain's been frying with bacteria for the last 6 hours, okay? So this is one of those you'd like to kind of shoot first and ask questions later. If you really think somebody's got bacterial meningitis, they're sick, they're ill appearing in front of you, you really think they got bacterial meningitis, you do not want to delay antibiotics for the CT and the LP, okay? So give them their antibiotics, then they can get their CT, they can get their LP. Yes, it can mess up the culture, the antibiotics, but it will not mess up the cell count. And the gram stain, over time, that'll go as well, all right? But your cell count's still fine. But you want to treat them. Okay, what about steroids in meningitis? This is about adults. So this is not, we're not talking kids here, we're talking adults with bacterial meningitis. Should we be treating them with some steroids as well? So this was a study done in New England Journal of Medicine many years ago, one of the LSA articles. The concept here is that someone's got bacterial meningitis, you give them a bunch of antibiotics, you kill off the bacteria, they release all those, evil humor, inflammatory mediator things, right? They release all these bad things, and it irritates your brain, and maybe they have a worse outcome. So the thought was, well, maybe if we pre-treat with some steroids, and then give them their antibiotics, maybe their brain won't get so inflamed when we kill all these bugs, okay? So that was a theory. Let's see how the study did. They took a bunch of adults. They thought that they had potentially bacterial meningitis. Randomized controlled trial. They all got antibiotics. Going to do that for sure, right? Half the group got placebo. Half the group got dexamethasone. They gave the dexamethasone either 15 minutes before or at the same time as the antibiotics, okay? So within 15 minutes of those antibiotics, they wanted to get it on early. And they followed them. They said, what were their outcomes? Well done, randomized controlled trial. And the outcomes were unbelievably impressive. The patients who got the steroids did much, much better. Better mortality, better morbidity, particularly when it was pneumococcus, which is very, very common. Okay, really impressive numbers needed to treat. Small numbers needed to treat to save a life. I mean, really impressive. So this stuff actually worked quite well. And the way they give it is the first dose is, before your antibiotics, and then they gave it every 6 hours for the next 4 days. Okay, so 4 doses a day for 4 days. Think of it that way. All right, so I think what this tells me is that if there's somebody who you really think has bacterial meningitis, they look ill, or maybe you did the LP and the CSF is cloudy, or more than 1,000 white cells on the CSF, and you haven't given antibiotics yet. You should have, but if you hadn't, pre-treat with steroids, then give them their antibiotics. Okay, that's really important. All right, does everybody need an LP? Excuse me, a CT before you do an LP? Do you have to scan everybody? We're like a young, healthy person? Well, the answer is no. This is another LSA article where they looked at what predicts who's going to have an abnormal head CT. And it was really pretty obvious stuff. It's nothing really shocking here. If you were over 60, if you were immunocompromised, if you had a history of something wrong with your brain, published in the Journal of Duh, right? I mean, that's pretty obvious, right? If you had a seizure within the last week, if you had anything abnormal on your neurologic exam, including just altered mental status, okay, so even just being altered. So anything bad on your exam, older, immunocompromised, they need CT scans before their LP. But you get a 23-year-old who's had a couple days of fever, headache, stiff neck, normal neurologic exam, otherwise fine, febrile, and you're like, man, I think this guy's got bacterial meningitis. You don't have to CT that kid. You can just, again, if everything else is normal, just go ahead and do your LP. That's one where if you do it quick enough, you might be able to hold the antibiotics and just quickly do your LP and then get the antibiotics on board, all right? So you don't have to scan everybody first. This is just to remind you, you don't have to memorize all this stuff, just to remind you, lots of other things other than bacterial cause meningitis. Syphilis, Lyme, TB, viruses, things like that. Okay, and we already kind of went over this, what the findings are. Antibiotics, this you got to memorize, 0 to 1 month. So you should circle this one. Under 1 month, there are 3 main bugs that cause bacterial meningitis. They're the same ones that cause neonatal sepsis. And that's Group B strep, E. coli, and Listeria. So Group B strep, E. coli, and Listeria are the 3 bugs. And because of that, you're going to treat with ampicillin. So ampicillin covers Listeria. Just remember, Listeria and ampicillin go together, all right? So you're going to give ampicillin for the Listeria, and then you're either going to give a 3rd-generation cephalosporin or gentamicin. So it's either amp and gent or amp and a 3rd-generation cephalosporin, okay? Group E strep, E. coli, listeria, AMP and gent, or AMP and a third-generation cephalosporin. And one more factoid to remember in these neonates less than 1 month, which is when you choose your third-generation cephalosporin, you do not want to choose ceftriaxone, okay? Because ceftriaxone, remember, kind of knocks bilirubin off the binding protein or whatever, so you get hyperbilirubinemia. So you don't want a jaundiced little neonate, right? We like to avoid that stuff. So no ceftriaxone in the neonates. Over a month? Sure. But neonates, no. All right? So AMP and gent or AMP and ceftriaxone for the little ones. All the other ones, people over 1 month, I already told you, it's pneumococcus or meningitis. So you're going to give them a third-generation cephalosporin and vancomycin. Pretty straightforward. So they can get some ceftriaxone or cefotaxime, whatever you want. Third-generation cephalosporin, vancomycin, very, very simple. All right? Okay, and yes, if you're worried about listeria for some reason, they have AIDS or whatever it is, you just add some ampicillin. Because remember, AMP is what you add on for listeria. And yeah, if they had a shunt in place or they just had brain surgery or something like that, of course, they could get staph. They could get other sort of skin bugs involved, right? But Vanco, still covering it, right? Same antibiotics that we're choosing, no different. So third generation and Vanco do a lot of things. The last thing I'll mention down at the bottom of the slide, on this one at least, is that what if you do the LP and there's a bunch of cells but no bugs, negative gram stain? Then you're thinking about viral infection, right? Viral meningitis. Think about herpes encephalitis, and that's when you use acyclovir empirically, right? So sometimes if the person's just looking really sick or they're having seizures or they have, any findings on their CT in the temporal lobes for sure, go ahead and give them some acyclovir empirically as well. It's not going to hurt. Okay, so let's move on to a couple other things now. I will be honest with you, this is some of the more painful stuff we're going to go. Luckily, you only got like maybe 5 more minutes with me on this one, and I'll get you later in the afternoon. But the neuromuscular stuff I want to tell you about. Guillain-Barré syndrome, otherwise known as Landry-Guillain-Barré. You get a 35-year-old comes in and says, a couple weeks ago I had a little gastroenteritis or I got a flu shot or something like that. And now I got some numbness and tingling of my fingers and toes. And I'm starting to get weak, but it's an ascending weakness. So ascending weakness, starting at the ankles, working its way up with hypo or areflexia, working its way down. Working its way up. So you start at you lose your ankle jerk, then you lose your knee jerk. Does that make sense? So a little tingling, and then ascending weakness, ascending hyporeflexia. That's Guillain-Barré syndrome. Loss of deep tendon reflexes are really helpful for that. If you do the LP, they'd have lots of protein. They need respiratory support sometimes because this ascending weakness can get to the diaphragm and they can have respiratory failure and need to be intubated. But they're getting admitted. They get ventilatory support if they need it. And then they do the usual things you do for, these sort of autoimmune disorders. This is an autoimmune demyelinization. So for autoimmune, you do things like plasmapheresis or intravenous immunoglobulin, IVIG, right? So progressive ascending weakness with areflexia working its way up, and you may have some sensory findings, that's Guillain-Barré syndrome. You got to know that one. Okay. Multiple sclerosis, also degenerating disorder, also in the central nervous system. So also, a demyelinating disorder, degenerative demyelinating disorder in the central nervous system. Multiple areas of demyelinization going on there. Usually young patients in their 30s, for example. Women more common than men, but men certainly can get it, and they tend to have more severe disease when they do get it. How do these patients present? There's lots of ways they can present. One presentation you have to know is optic neuritis. Optic neuritis is a classic first presentation of multiple sclerosis. Anybody who's got optic neuritis automatically gets an MS workup, okay? Absolutely. So the person comes in with maybe unilateral visual loss, some painful visual loss. You look back there, maybe you see some papillitis, or maybe it's retrobulbar, so it looks normal and you don't even see anything, okay? But they got optic neuritis, they get a workup for multiple sclerosis. Don't forget about our bilateral internuclear ophthalmoplegia, this thing, right? That's pathognomonic, okay. The other sort of presentation that I have seen very commonly is a young patient, classically a young woman, comes in the emergency department with vague neurologic finds. I'm numb over here, and I'm weak over here, and I'm this over there, that sort of thing, right? And it's 2 in the morning, and you're really tired, and maybe even grumpy, and you're thinking, oh, come on, this has got to be, they've got to be faking it, right? No, not faking it. Don't go down that pathway. You're going to get totally burned, okay? Not good for you or the patient. It's the reason you can't find the lesion is it's multiple sclerosis. It's not unisclerosis, right? There's multiple lesions. They're all over the place. And because of that, the defects do not always make sense, particularly at 2 a.m. when you're grumpy, all right? So do not blow these patients off. Make sure that they get close follow-up and do get evaluated, because some of those patients are going to have MS, so you need to get them followed up, all right? Diagnosis of multiple sclerosis, if you do an MRI, you'll see the plaques. If you do the LP, you'll see a bunch of protein in the LP. Those are those oligoclonal bands. Remember that word? Basically, it's just a bunch of antibodies within the CSF. That's what they are. And this little gel here is meaning to show you the difference. So again, let me just show you here. So normal patient, abnormal means they have multiple sclerosis. Okay, if you look at the plasma of the normal patient, and you look at the plasma of the abnormal patient, they look the exact same. There's no difference. The normal and the abnormal, the plasma is the same. Where the difference is in the CSF. In the person with multiple sclerosis, they've got this, that extra purple band there going on there. That's the oligoclonal bands. It's basically a bunch of extra protein sitting within the CSF, all right? There's these things called visual evoked response. This is where you have somebody look at a visual stimulus and they measure how long it takes for the brain to receive that stimulus. Think of it as like a nerve conduction study of the eyeball and the brain. Think of it that way, right? They show you the little flashing or whatever spinning black-white thing, and they measure how quickly you pick it up back there. So that's going to be slowed in multiple sclerosis. It just kind of makes sense. It's a demyelinating disorder. So you'll have slowed, these visual evoked response or auditory evoked response. Any of these sort of kind of conduction tests are going to be slower. Treating multiple sclerosis in the ED, we tend to treat the exacerbations, right? Somebody comes in for an exacerbation of their disorder. So we're going to put them on steroids. Usually they're going to get some solumedrol, right? So methylprednisolone is what we're going to do down in the emergency department. Maybe if they get admitted, they do plasma exchange or something like that. But basically steroids is what we're doing for the exacerbations. Longer-term management of multiple sclerosis, however, are all these immunomodulating agents. They call them long-term disease-modifying agents. They're immunomodulators. So these are things like interferon, right? They kind of alter your immune system, right? So interferon will do it. They have these new things which are actually where they have antibodies to the B cells that are causing all this problem, where they can actually kill off the B cells. So things that manipulate your immune system are the things that chronically they're using to treat multiple sclerosis. But they come in for their exacerbation in the ED, and it's basically giving them some steroids. Okay. I think I will stop right there, and I'll see you later this afternoon. Thanks for all your attention.